Thank you, everyone. Thank you, Dr. Karanja, for that kind introduction. So, in the intro, we'll just in, and this study is it's a really, I think it's a nice follow up from what Dr. Njuguna was talking about, uh, thinking about mental health in the workplace, because now this is an intervention that actually addresses mental well-being of healthcare providers at the workplace. So the bit at the end of the goal, we at the end of the day, we want patient's experience, but how do we improve patient experience without addressing the people who are providing care to the patients themselves? So I'll talk about this study. It's called Caring for Providers to Improve Patient Experience, and intervention that we carried out last year in Migori County. Um, so it's a pilot, we call it in short CPIPE study. This is our study team. It's composed of members from the University of California, San Francisco. The main PI is Patient Afulani, and also members from Kenya Medical Research Institute and also from Global Programs for Research and Training. So my outline, I'll go through the intervention, how we came up with the intervention, how we developed the intervention, a bit of a background on that, and the strategies themselves are the ones we are using for this particular intervention. Then I'll go through our evaluation of the intervention. Because this is a pilot study, we really just focused a lot more on the acceptability and feasibility, but also we look at preliminary effectiveness of this particular intervention. So as a background, research evidence has continually shown that poor person-centered maternity care contributes a lot to high maternal and neonatal mortality, especially in sub-Saharan Africa. And not only just maternal and neonatal mortality, we also have a lot more of disparities in the use of maternal health services. So mothers might, if they feel like they were not taken care of nicely within a facility, they would choose to not use the healthcare service to deliver in those specific health facilities. Maybe they would go to traditional birth attendants and probably they would be delivering at home because of the treatment that they received within the facilities. Now we've talked about poor person-centered maternity care. What is person-centered maternity care? Person-centered maternity care is care that is responsive, care that is compassionate, and care that is respectful. So there's very little research in terms of, we know about person-centered maternity care, but there's very little research that looks at what are some interventions, effective interventions that actually address, that help to improve person-centered maternity care. So prior to this pilot study that I'll be presenting today, the results of, we have undertaken about 3 other studies still in the same area of Migori County. And prior to this, we had undertaken a mixed method study where we interviewed providers. For the quantitative part, we looked at stress levels among providers, we looked at burnout levels among providers, and we found that they really had high levels of stress and burnout within those facilities. And according to literature, we know that burnout leads to a lot of numbing, a lot of reactivity, and also a sense of depersonalization. I'm sure some individuals here have gone through burnout. Those are some of the experiences. And when an individual is experiencing this, it really does have a high impact on the kind of care the provider is providing. So it has an implication on the quality of care, including that it impacts on person-centered maternity care. So also one of the things that we were measuring qualitatively is around the implicit and explicit bias. And we know that implicit and explicit bias contributes to person-centered maternity care disparities. Now, implicit bias is bias that is more at an unconscious level. Explicit bias is bias that someone is actually aware of. In the context of our research in Migori County, the previous studies, the CPIPE phase 1 studies where we were looking at these kind of biases, we actually found out that certain aspects, for example, socioeconomic level of a woman would determine how the woman would be treated when they are going to deliver. If maybe they look like they're coming from a lower socioeconomic uh, level, you'd find that the treatment would differ from someone who comes from a higher socioeconomic level. And aspects such as ethnicity, such aspects such as even occupation, they would say maybe teachers tend to be, like busybodies, and then they would not be, they will just look at them and think this is going to be a difficult patient. If someone is younger, or like a primigravida, they would look at them and just say, this one is going to be a difficult patient. So the treatment varies, whether unconsciously or consciously, based on certain factors, from socioeconomic levels to occupation to age and aspects like that. So we measured those and we saw there's also higher levels of that, both explicit and implicit bias. And then also, and we know that according to a lot of research that has been done, these deeply felt biases are more likely to actually emerge when people are stressed. The more stressed an individual is, the more the biases come out based on those aspects, those factors that I've just talked about. So also we found out from literature that the stress and bias are hardly discussed. When it comes to quality improvements of maternity care in Africa, they really never really focus on stress. They don't focus so much on bias. And the focus tends to be primarily around the technical aspects of how do you manage prolonged labor? How do you manage postpartum hemorrhage? The technical aspects of it, but they don't look at the provider as a human being and how about their mental well-being, their levels of stress, burnout, and also biases. So there's very limited research that looks at interventions that address provider stress. I think this is something Dr. Mary from Kisi was saying. How about the providers themselves? What is happening? What interventions can we put in place for providers themselves? So this one is specifically targeting maternity care providers. So again, just to reiterate that we did the study in Migori County. The intervention site were 2 facilities, and then we had a control site for 2 facilities there. So the first objective, as I've just hinted on earlier, was to design an intervention to improve. The first objective was to design an intervention to improve person-centered maternity care, and the focus was on provider stress and bias. And this had been informed by a lot of previous research to see what are the problems that maternity care providers are experiencing. So how did we go about designing it? We used a very iterative process. Here we did a lot of formative research. We talked to the providers. We asked them about what would work, how long should the intervention be, what kind of trainings would you need to be put in place. If you're doing a training on stress management, which areas should we focus on? So we did a lot of formative work. We also based it on existing literature, behavior change theory, and then a lot of feedback from key stakeholders in the leadership of the county health management team feedback. So we came up with these strategies that focus around 5 pillars. The first pillar is on training, and for the training, this included two-day training, and the training focused on what even person-centered maternity care is. We talked about stress management. How do we manage stress? And we brought in, showed them even practical exercise about deep breathing, about meditation. Then we did a lot of practical exercises also around dealing with difficult situations. For example, there was simulations around prolonged labor or simulations around postpartum hemorrhage using a model called Pronto. But within the simulation of managing, let's say, postpartum hemorrhage, we would still bring in aspects of, so did you do the deep breathing? Did you do the pause? Did you, communicate? How did you communicate? So bringing in those elements, but within the practical simulation of managing a difficult situation. So aside from that, we also continued with the trainings that we offered on stress management, on unconscious bias, or explicit and implicit bias. We also continued with those same classes within WhatsApp messaging groups. So we had a WhatsApp group for the intervention, and we would send them every week. Would send them a message, just part of the information that were delivered during the 2-day training. There was also the peer support groups, and within the peer support groups, they used to meet every month. It was led by themselves. They had a champion that they picked who was able to lead these peer support groups. And during the peer support groups, they would do a lot of debriefing and even sharing and dancing and you know talking about the problems that were going on and how to solve them. Then there was also mentorship. There was embedded champions and leadership engagement. In the interest of time, I think I'll rush a little bit. So the second objective was to pilot now this particular intervention after designing it and to evaluate the acceptability and preliminary effects. So we used, generally the entire design was a pre-test, post-test, and an equivalent control group, coupled with that convergent, essentially a quantitative method that also had a qualitative piece aligned to it. If you look at the flow diagram on your right, shows how there was at baseline, we did a survey of about a total of 84 people. This was about 40 in the control and 40 in the intervention group. Then the 2-day training. Then we had those monthly refreshers, peer support, mentoring, embedded champions, and the leadership engagement. This ran for a period of 6 months. At the end of the 6 months period, we did an endline survey and we looked at various parameters. And we also did now in-depth interviews to better understand how their experience had been. Some of the quantitative measures as shown looked at stress knowledge, implicit bias, perceived stress, burnout. So those are some of the measures we looked at, and social demographic factors. For the qualitative in-depth interviews, we also looked at their experiences, the perceptions about various strategies, the impact of them, among other things. So for the analysis, we did descriptive analysis, the quantitative arm of the study, bivariate and multivariable, and also difference with difference analysis. I'll just present a few of the quantitative findings in the interest of time, and also qualitatively, we did a thematic analysis. So when you look at the results, for both control and the intervention group, they're more or less the same, apart from marital status, where we had more married members within the control group compared to the intervention group, and this was statistically significant. We had more females, as imagine, because this is maternal healthcare providers, and mostly between the age of 31 and 40, most of them were nurses and midwives. In terms of training, this was interesting that we asked them how many of them had had training, both in the control and in the intervention group. How many had had training on how to deal with stress? Only one person said they'd had some training in the control group and only one in the intervention group. So again, there's definitely a gap that we found even as we did this intervention. Training on unconscious bias, one person in the control group and 6 had had that in the intervention group. And also on interpersonal interactions, again, very few numbers. For the findings for the multivariate analysis, we did see significant differences for the intervention group when we look at the baseline, at baseline and end line and compare. When it comes to stress knowledge and knowledge on implicit bias knowledge, they all was significant changes. There was increased knowledge at the end line and reduce perceived stress, reduce burnout at the end line. For the control group, we did find some smaller changes compared to the intervention group, but specifically for burnout and explicit bias as well. But higher changes definitely in the intervention group. So in summary, what are we saying? For the quantitative results, at endline, there were statistically significant changes, showing increases in stress and bias, decrease in perceived stress, decrease in explicit bias, and increase in self-reported person-centered maternity care. There were just smaller or no significant changes in the control group. For the qualitative, we also did the in-depth interviews at the end of the intervention. The idea was to look at acceptability as well. of this pilot. We saw themes that align at individual, interpersonal, and institutional level. So in the interest of time, again, I'll just give a few of these comments. One of the themes was around increased competence in managing clinical complications and difficult situations. This was after the intervention. One of the members said it helped me a lot because whenever I have any stress in the wards, then I know how to cope with, especially PPH, postpartum hemorrhage. The anxiety that I had when I got PPH, at least I can now handle it so well and attend to it properly without fear. I've really learned a lot. Before attending the trainings, I did not know how to handle difficult patients. And after the training, I can now handle. So it was around competence. There's one who said, I know how to calm down. I'm not the bitter nurse I was before. I know how to cope with stresses that we are going through in the maternity. I can handle difficult cases. The way I used to freeze when I got emergencies, I no longer freeze. I just breathe in and out and I quickly do what is expected of me. So those are some of the quotes regarding now competence. We had some quotes regarding well-being and personal experience. They talk about how sharing my stress with my colleagues now made me to enjoy coming to work. And my anger towards the patients was also dealt before I could start shouting at mothers so much in the maternity without bothering that mothers are in pain. And that's why maybe they were not cooperating. But nowadays, it's easy to find me shouting at them. It's not easy to find me shouting at them. Even when a patient is messing around the linen, I just ask the caretaker to talk to the mother quietly. So those are some of the quotes we got. Um, so we also, another theme was around that relationship, supportive work environment. They said after the training, it made me more open to my colleagues. I listened more. And when somebody is talking, I let them talk, even if I was rushing somewhere, unless it's an emergency. I give them a listening ear. Um, even advocacy aspects because of that leadership pillar that we had. So in our discussion, the CPIPE intervention outcomes are actually, we saw it more of a synergistic effect. That's why we got the outcomes that we did. And there was I think in the results I rushed over this, the implicit bias, we did not see a very significant change when it came to implicit bias. But then we didn't find it very surprising because the training really does not change the underlying associative processes. Um, the so that's why we thought maybe that's why we didn't see specifically for implicit bias. But the other aspects of the parameters that we're looking for changed. Um, and we've actually looked at data around implicit bias, and there's a low test and retest reliability of that implicit bias. Some of the limitations, it's a self-reported measure. So again, that's always has been a lot of psychiatric studies behavioral studies are like that, self-reported measures, and there was no patient-reported measures for this particular study. Um, we just asked about their perceived person-centered maternity care, if it had changed. We asked the providers. So for the strength, it's the first one to show the effect of an integrated provider-targeted intervention on stress, on burnout, and also on implicit and explicit bias, as well as reported person-centered maternity care. So in conclusion, we think it's a highly acceptable intervention to providers. The preliminary analysis shows some effectiveness, especially in increasing stress management and bias knowledge, in decreasing stress and burnout and bias levels, and also in increasing self-reported person-centered maternity care. So currently, we have just managed to get another grant, an R01, whereby we're going to run now a larger scaled cluster randomized control trial both in Kenya and Ghana. And we've already started. We are now at the point of about to start to implement. We're getting approvals. And this is going to be more robust and it's going to actually ask the mothers themselves whether they've experienced changes